We are live.
Good morning, everyone. Welcome to the 5th International Ophthalmic Conclave organized by the All India Ophthalmological Society. Welcome on Republic's Day on 26th of January. The first session for today is Infectious Keratitis, a Preferred Practice in 2025. The moderator for the session is Dr. Sridevi Nair. I'll be your session coordinator, Dr. Arshi Singh. Our hosts for today are Dr. Radhika Tandon ma'am, Dr. Namrata Sharma ma'am, Dr. M. Vanati ma'am. We welcome you all. And our expert panel consists of Dr. Christopher Liu, Dr. Elmer Tu, and Dr. Sonal Tuli. Thank you all for being here. This is a global platform for all the leaders and the experts in your selected fields, and we are looking forward to a wonderful session today. Ma'am, Dr. Sridevi, could you please start sharing and starting your session?
Yeah. Thank you, Dr. Arshi. So thank you for introducing me and the session. So this is a session on infectious keratitis, the preferred practice in 2025. I thank AIOS for this platform, and I thank all our chairpersons as well as our expert panelists and speakers for joining us today. I would like to introduce our esteemed chairpersons, Dr. Radhika Tandon, who is presently the professor and chief at Dr. R.P. Center for Ophthalmic Sciences, AIIMS, New Delhi. Dr. Namrata Sharma ma'am, I think ma'am hasn't joined us yet. So ma'am is also a professor in cornea, cataract and refractive surgery services in AIIMS RP Center. She is also the chairman scientific committee AIOS and past president Cornea Society of India. And our third chairperson is Dr. M. Vanati. Ma'am is also a professor in cornea, cataract and refractive surgery services at RP Center AIIMS. She's also presently the editor of Indian Journal of Ophthalmology. I now invite Radhika ma'am to open the session.
Thank you, Sri Devi, and thank you everyone for having joined from different corners of the world and different parts of India. We're very grateful to AIOS for giving us the opportunity to put together this session on infectious keratitis. It is designed to cover preferred practice patterns in 2025. But as you know, in a short time, it's not going to be able to cover the entire gamut of diseases and therapeutic protocols. So what we've done is have some key speakers who will cover the key topics, particularly an overview and then the diseases which are a challenge, combined with some real-life case scenarios, which will sort of illustrate. You may have something which is written as a preferred practice pattern, but when you're faced with a patient, things may be a little bit different from what what is recommended and what you can actually handle. So we want to give a little bit of a practical insight to everybody as well. Before we go ahead with Sri Devi's overview, since we have renowned people from all over the world, can I just ask Professor Liu and then Dr. Elmer and then Sonal to just give a few thoughts of their own, just so that everybody gets a chance to understand how difficult it is to handle such cases. So Professor Liu, please.
Good morning. I'm in Hong Kong at the moment, and it's a real pleasure to join you for this session. From my point of view, always prevention is better than cure. So I think contact lens hygiene and farm workers and prevention of accidents, these are all very important. And then the next thing would be rapid diagnosis. And getting onto the right treatment. And finally, my hobby horse, to avoid steroid eye drops where contraindicated and where not necessary, and where the deployment of steroid would either make no beneficial effect or make things worse. So that's my minute's worth. Thank you.
Thank you so much, Christopher. May I request Elmer to share a little bit of your perspective?
Thank you, Dr. Radhika, for inviting me along with the other organizers today. It's certainly an honor to be here. I find infectious keratitis fun. Unfortunately, I agree with Dr. Liu that prevention is always better, but always a little bit exciting when we had infectious keratitis arrive from history taking to examination to testing. Really, it's a one-on-one battle, and I think it's exhilarating when you win and very disappointing when you lose. Thank you very much.
Thank you so much, Elma. And Sonal, it's your turn now to share your pearls of wisdom.
Oh, thank you. And thank you, Dr. Radhika, for inviting me. I'm really honored to be here. With infectious keratitis, we all know that even experts are not always the experts. So we also have cornea specialists have a hard time figuring out what the infection is and how to treat it appropriately. To echo, Christopher and Elmer, you don't want to put the wrong treatment on. And so I'm really looking forward to this session to hear from experts and learn just like you all are.
Thank you so much, Sonal. So now, Sridevi, with that background, you are going to give an overview. So can I request you to present your slides?
Yes, ma'am. So, ma'am, I'll just share my slides. Yeah.
And thank you, Namrata, for joining, and Vanati. We will take your pearls of wisdom just after Sridevi's talk.
Thank you.
Yeah, are my slides visible? No.
Yes, they are visible now.
Yeah, right. I'll just. Okay, there is some issue. Sorry, just a second. Got minimized. There is an issue with the slides are minimized. Like I can't see the entire slide. Can somebody at the back end help?
For us, we're seeing your on slide
Yeah,
revision
I'll
book
just, yeah.
slide.
Okay, is this okay, ma'am? Can you all see the slide now?
Not on
Yeah,
slideshow yet,
yeah,
but
sure.
you can
Okay.
see the whole slide.
Yeah, I think it's on the slideshow. Is it on the slideshow mode now? No,
No, this
Not
is
yet.
I think there is a
It's
hang,
been
ma'am, because
hanging.
yeah, there is some issue. There is a
Okay.
slight lag in this thing. I'll just try again.
Ma'am, try clicking on the upper bar where it says slideshow. Sometimes the bottom one
Right.
wouldn't
Okay, I
work.
think now it'll start working. I can see that now. Yeah. So is it
Yes.
okay now?
Okay.
Yeah.
Yes, ma'am.
So I'll be speaking on the diagnosis and broad principles of management of infectious keratitis with a particular focus on the role of confocal microscopy in these cases. I have no financial disclosures. So conventionally, the diagnosis of microbial keratitis has been based on clinical history, examination, and microbiological investigation. And you need a very systemic synthesis of the information that's obtained from all these aspects to make a proper diagnosis. In addition, we also have adjuvants such as in vivo imaging, including aesocity and in vivo confocal microscopy, which help us in cases where we can't arrive at a proper diagnosis. So the challenges that are associated with these approaches of microbiology or clinical features alone is that up to 30% of the infections are often misdiagnosed even at the hand of experts, as said by Professor Tuli. And especially in cases of fungal keratitis, there has been a very relatively low positive predictive value when diagnosed based on clinical features alone. So these indistinguishable clinical features are apparent from these case examples. As we can see, this was a young male with dense intrastomal infiltrates and was diagnosed as a case of fungal keratitis elsewhere, possibly candida, but eventually turned out to be a case of acanthamoeba keratitis. This was another case which was diagnosed as a case of geographical viral keratitis, again turned out to be a case of acanthamoeba keratitis. And this was a patient who had intrastomal infiltrates with the typical feathery margins and branching patterns, suspected as fungal keratitis elsewhere, but eventually turned out to be pythium. So the next challenge in these cases is the incidence of polymicrobial infection. So even if you detect one organism on microbiology, you might be missing the second or even the third organism. And there is an incidence, the reported incidence is about 30%, or 1/3 of the cases may have a polymicrobial infection. Most commonly, what we see is a bacterial and a fungal co-infection. As in this case here, we can see that the patient had Candida aspergillus as well as Coagulase negative staph positive. But a more notable association that has been reported is that of acanthamoeba and fungal keratitis. So Anita Raghavan et al., they reported that in 22 culture positive cases of acanthamoeba keratitis had concurrent fungal keratitis. So this is a very important association, and it is more common than what we assume it to be. So these are two case examples where the patients were diagnosed as acanthamoeba keratitis based on the clinical features, but eventually they were found to have concurrent fungal infection as well. The third issue is that the culture positivity rates in both for bacterial, fungal, as well as acanthamoeba keratitis is relatively low, which is consistently like less than 60 to 70%, which again makes it a challenge in diagnosing these cases, and especially the long turnaround cases in cases of fungal and other atypical organisms, which brings us to the role of adjuvant imaging techniques as well as molecular diagnostic tools in these cases for their diagnosis. So corneal imaging in infectious keratitis, we predominantly employ anterior segment OCT or in vivo confocal microscopy. Now, the ASOCT is useful to determine the depth of infiltrates. It can even assess the progress after treatment, and as well as certain microstructural alterations, which can help you differentiate between bacterial or fungal, or differentiate between active and inactive viral keratitis. However, we cannot like directly visualize the pathogen using an anterior segment OCT. On the other hand, in vivo confocal imaging allows on-FOSS imaging, which allows the assessment of a cornea at the cellular level and allows direct visualization of the pathogen. So with a very high lateral resolution of around 1 micron that we have with our HRT RCM confocal microscope, it's a really great tool. And the role of confocal microscopy is more pronounced in cases of atypical keratitis, which is predominantly caused by fungal, acanthamoebal, nocardial, and pythium, as these cases are often very challenging to treat because of their to diagnose because of their low culture positivity rate and the clinical misdiagnosis when based on clinical features alone, as well as the variability in the clinical time and clinical signs and the long time taken for the cultures to grow these organisms. So the sensitivity in for confocal microscopy in cases of fungal and acanthamoebal keratitis is quite high as reported in the literature, but the most papers that have reported a rate of more than 80 or 90% may be falsely overestimating this sensitivity, because the controls for these are culture positive cases. So since the baseline culture positivity itself is low for these cases, we might be actually missing out on the false negative cases that are culture negative. So this is a case example where a 24-year-old male presented with complaints of pain and redness for a month. He was diagnosed as fungal keratitis based on a smear positivity for fungal hyphae, but the patient had an inadequate response to treatment and was referred to us. The repeat smear at our center did not reveal any organisms. So we went ahead and did a confocal microscopy to look at what we were missing, and what we did see were these hyperreflective round cysts with a hyperreflective background. We also saw the classical double wall cyst with a hyperreflective halo, as well as the linear arrangement of cysts and the clustering of cysts that have been classically described in acanthamoeba keratitis. In addition, we also saw these broken hyphae, which were possibly related to the treatment that the patient had undergone for the fungal keratitis. So the patient was started on anti-acanthamoebal therapy as well, and as we can see, 12 weeks post-treatment, the patient showed good response with scarring. So acanthamoeba keratitis, diagnosing on confocal microscopy, it has a very useful role in that aspect. And as we can see, the round to ovoid hyperreflective objects are the most commonly seen in these cases. They are highly sensitive. The size is around 25 to 30 microns, or maybe even a little smaller. At times, we'll see the target sign with the surrounding hyperreflective halo or a classical double wall structure, and the binary appearance and the filing of structures. So as we can see here, this is the clustering of the ovoid objects, and we might even see trophozoites-like structures, but these are often, they may be confused with other non-specific objects as well on the scan. And the linear filing of the cyst, it's quite specific for acanthamoeba keratitis. So when we look at the specificity and sensitivity, so while the hyperreflective cysts are highly sensitive, their specificity is limited because they may be seen in around 50% of the fungal and bacterial keratitis cases as well. Whereas the appearance of a signet sign or a target sign, a double wall cell, or the filing and the clustering of the cysts are much more specific, though their sensitivity is lower. Certain factors have been associated with poor prognosis in these cases, such as the deeper location of the cysts, as I said, the clustering and the linear chains of cysts, the binary cysts, as well as the target sign. It's also important to differentiate between the inflammatory cells and the hyperreflective cysts that are seen in these cases of microbial keratitis. So as compared to the microbial cyst, the hyperreflective cysts that we see on the right side of this slide, I've just inverted the colors for a better representation. We see that the inflammatory cells, they don't have a well-defined wall. They are less homogeneous. They are not equidistant, and they show significant overlapping or squeezing of the cells together, as opposed to the cysts, which are relatively separate with a nice well-defined wall and a homogeneous hyperreflectivity. Next, the role of confocal microscopy in fungal keratitis has also been very well explored. But just as we know that, so like in everything else, there is no one rule fits all. So the classical appearance is that of branching filamentous hyphae, which may or may not show dichotomous branching. The size, the width varies from 3 to 10 microns, and they may be up to 400 microns long. So they might span the entire scan of the entire image, or one scan which is around 400 microns, and they have this ribbon-like pattern. Classically, they may show septations, may not show septations. And the two recent studies showed that though classically Aspergillus was associated with an acute branching and Fusarium with a 90-degree branching, it is not really possible to differentiate between the two on confocal microscopy alone. So while we discuss the classical appearance of hyphae, we may also have a variable appearance of hyphae based on their size and distribution. So the image on the left side is the same of that of the patient on the left side in this image. It's just that the level of scanning is different. So this is a deeper stromal layer. And here you can see the hyphae are much smaller. At some places, you can see the double wall appearance and the septations, but they are less regularly branching and smaller in size. This is another patient where post-treatment, you can see that the appearance of hyphae is different. So in addition to the classical appearing hyphae, you may also have findings which are suggestive of a fungal keratitis. So here you have isolated or several curvilinear structures that have a variable reflectivity. They don't have the classical long branching structures. The branching might be much more ill-defined. And again, but this is a case of alternaria keratitis. So you need to take into account the clinical picture as well as the microbiological findings when you look at the confocal images for these patients. The one more structure that we need to look into these cases are the conidiophores, which are basically spore-like structures that are seen in confocal microscopy of fungal keratitis. So they have been classically associated with demeticious fungi. As we can see, this is a case of acrimonium keratitis with a conidium, and in a case of Aspergillus keratitis as well. So this was a patient who did not respond well to treatment, and we can see this triradiate branching of a conidiospore. And here is a case of penicillium keratitis, again showing the triradiate branching. And this is a clavate conidiophore, which was seen in a case of trichophyton. So the appearance of hyphae has also been studied in relation to response to treatment on confocal microscopy. And as you can see, we can see that there is a reduced density of hyphae in all these patients post-treatment. The classical branching structures are not there. The hyphae are much smaller, often broken. Also, what we can see in this is that in addition to the reduced density of the hyphae, we also see a reduced density of the inflammatory cells in these cases, as opposed to the active treatment naive cases. There are certain structures on the confocal imaging which might be confused with hyphae and should be differentiated, including the corneal nerves as well as collagen bundles and dendritiform cells, which are basically inflammatory cells. And usually you can make out a cell body from which there are the branching processes. The inflammatory cell pattern seen in a case of microbial keratitis on confocal microscopy can also provide you certain clues to the prognosis as well as the organism that is involved. So these are the features that have been classically described in a case of acanthamoeba keratitis, where you have a much greater density of dendritic cells, particularly in the anterior stromal layers, as well as the keratocytes, which are much fewer and absent and have been converted into these fibroblasts or myofibroblasts, as we can see at the image in the lower left pane. And these are the features that have been associated with fungal keratitis. So you can look at the honeycomb appearance of the inflammatory cells, which have been associated with poor prognosis in these cases, as well as the stellate appearance of interconnected keratocytes or cells without the nucleus in these cases. So these are anucleate cells, and these have been associated with poor prognosis of this thing in case of fungal keratitis. Confocal microscopy, despite all its advantages, has certain limitations. The most important being its high level of user dependence or observer dependence, and the cellular morphology itself may change with treatment, may be variable based on the level of scan. The area scanned is relatively small, so if you're not looking at the area of active lesion, you may not be able to detect the organism. A minimum of 1,000 scans is recommended. In addition, it's highly dependent on patient cooperation, and also sometimes a large number of inflammatory cells or the necrosis may obscure the organisms itself. And of course, as we discussed, it cannot differentiate between the different species of fungal keratitis. So this is a broad outline of treatment for microbial keratitis, which I'm sure we'll be discussing in detail in the further talks. And as we can see, we initially start with an empirical treatment and then tailor our treatment based on the microbiological evaluation results as well as clinical response to the treatment. So what is the role of confocal microscopy fit into this treatment algorithm is that usually, so while a lot of authors might recommend that you should do it in all cases of microbial keratitis, as I said, to rule out the cases of mixed or concurrent infections, what we usually do in clinical practice is to perform it in cases of, atypical microbial keratitis where we are suspecting atypical organisms, or in cases of non-responsive cases. So once you see any typical signs of filaments or double wall cysts, then maybe you can just go ahead and start with the respective treatment, even if your microbiology is negative. However, you might have even suggestive findings, as discussed. We saw in the case of fungal keratitis where you may not say classical hyphae, but they may somewhat appear like hyphae, in which cases it might be a good idea to repeat the confocal, maybe in a region where you expect a more active kind of proliferation, or you can wait for the microbiological report or repeat the microbiological evaluation. When you find no typical or suggestive findings in confocal microscopy, then probably it's best to rely on your microbiology, repeat it, or do a corneal biopsy, or maybe even consider an alternative diagnosis. So to summarize, the diagnosis of microbial keratitis is basically it relies on the clinical history, features, as well as microbiological tests, but these are associated with certain diagnostic challenges due to the overlapping clinical features, polymicrobial infections, and the low culture positivity, in which case the adjuvant imaging, such as confocal imaging or ASOCT, may act as a valuable diagnostic aid, especially in cases of atypical keratitis, so they have the limitations of being highly observer and operator dependent, and thus microbial diagnosis still remains the gold standard for these cases. I thank you for your attention, and I'll just stop sharing my slides now.
Thank you very much, Sri Devi. You have given a wonderful overview. Can I request Namrata to please also add a few comments about, because we do know confocal microscopy is extremely expensive, and you have a great experience with scanning ASOCT images as well as ConfoScan. And as a preferred practice pattern, what should we tell our audience about these newer tools?
So I think that was a wonderful presentation, Sridevi. You just covered everything that anybody would want to know about confocal microscopy and microbial keratitis. Having said this, I think as far as imaging is concerned, anterior segment OCT is more accessible and is inexpensive, although it doesn't give you so many features. We did report that you can see areas of necrosis over there and also activated keratocytes, which would tell you whether the ulcer is active or not. About confocal microscopy, it's like a scan of the cornea. The only problem is, and unfortunately, even the company is now not making confocal microscope. So we have to do with whatever we have. But it gives a great insight and also tells you whether the prognosis is going to be good or not so good. But having said this, microbiology would still remain the mainstay for treatment of microbial keratitis. In situations where you actually, when you have a catch-22 situation, when there are polymicrobial infections or where there are recalcitrant infections, I think those are the times when confocal microscopy may come to your rescue, and you would need it. You may not need it routinely for all cases. And I think we have to also coax the industry to continue to make it or find somebody else who can make it, because it's a great tool otherwise, not only for microbial keratitis, but otherwise also.
Thank you so much, Namrata. So Dr. Revati will be giving us the preferred practice patterns with respect to fungal keratitis. And she needs no introduction, particularly the tremendous amount of work which has been done in this field in her institute. So over to Revati, please.
Can you see my slides?
Yes, they're visible, Revati.
Yeah. Thank you, Dr. Radhika, and thank you, AOS, for giving me this opportunity.
Your voice is a little low volume, so can you come a little closer?
Yeah, maybe, yeah. Yes. Am I audible now?
Much better.
Yeah, thank you. I don't know, something wrong with my thing. Now I'll be talking about the fungal keratitis management. Of course, the interest in fungal keratitis is always there in probably our kind of warm countries, because majority of our infections are very severe and filamentary. But the worldwide interest started, as you know, after that contact lens associated epidemic. And after that, consistently, even in the Western world, this filamentary keratitis is especially keeping on increasing, though not in an alarming way, but it is consistently increasing. And that's how the outlook is different now. And these are the different fungi we have. And Pythium is not exactly a fungus, but it's just because morphologically it can mimic. It is included here. And the coming to the different pathology, actually, what we have to remember, from the pathogen side, it may be in each area, the pathogen may be different, its strain may be different, and its the way it affect the cornea also may be different. It affects the cornea by releasing mycotoxins and its invasion. And it can invade even intact desmoid membrane, that we have to remember. And from the host response also, there may be specific and non-specific. Both these responses are important because fungus is a large organism. A maximum our therapy can break it into small filaments, and it has to be removed by the active macrophages. But at the same time, the tissue destruction caused by the host response also should be kept in mind, and that has to be also handled properly. And coming to the diagnosis, Dr. Sridevi has given beautiful overview, and still we should not forget about the clinical features. We have to be well versed because not every one of us can have confocal and even the molecular biological diagnostic techniques. So we have to be well versed with the clinical part also, and the basic gold standard laboratory investigations also we should be very clear. And then confocal is, of course, as this case here, which can be viral, which can be acanthamoeba, which can be anything, but then confocal revealed that it is a fungus. So something like that, and any deep infection also, we can use the confocal. And we should not forget the role of AC tap, because fungus as such can invade into the anterior chamber. So we can do even AC tap or aspiration from the endothelial plaque, and the corneal biopsy also can add on to your diagnostic tools. Coming to the medical therapy, we should know what are the drugs available, how they are acting, whether we can give monotherapy or combination therapy. Same way, the surgical managements are also should not be forget, that we should be able to use them as and when required. And among the molecules, we have polyenes, which are commonly used, and which will affect the cell membrane permeability. And azoles inhibit again cell membrane, the ergosterol, by which they act. Only echinocardins affect the cell wall and cause the cell wall death. These are the different areas. Why we should know? When we want to combine two drugs, it's not advisable to combine drugs from the same group, because they will be targeting the same area. So it's better to combine drugs from different group. But in addition to this, there may be many factors which will play a role in any getting a synergistic effect or additive effect, including the host response. But those things, it's very difficult in vivo to understand. So at least logically, we should be able to combine only drugs from different groups, and we can combine different modes of therapy also. Coming to which antifungal to select, of course, Mutt has given a very clear answer for this, unlike many of the randomized trials, which again finally will end up with telling like we need more more studies, but here categorically it clearly says that natamycin is much superior than voriconazole. But we have to remember this is done in a one locality. Most of the cases are enrolled in South India, and where the fusarium is the maximum, as you can see the breakup here. And in fusarium keratitis, definitely it has a leverage. In case of non-fusarium keratitis cases, both are almost equal. Not a significant difference was seen. This is what Mutt has clearly showed. And later this has been commented, and later reappraisal was done again from South India, same environment. Again, they found also natamycin is better. And now, as I said, the filamentous fungus is gaining more importance worldwide, and especially fusarium. This information is of quite important value. So always we start with 5% natamycin as the first line drug. The other polyene amphob is only we consider maybe when the response is not so good, or if it is an aspergillus keratitis or candida keratitis. Of course, we have azoles, among which voriconazole is the most favored drug nowadays. And we also have itraconazole and fluconazole as drops. But fluconazole always we found personally that more effective against candida, not in filamentous keratitis. Caspofungin also basically it more effective against candida, but 1 or 2 cases of fusarium keratitis where natamycin was not that effective. I tried, and 2 cases gave good results, but I don't know whether really this will be in future, because this we are again expensive drug we have to reconstitute. And also we can consider about combination therapy. Now we'll see some scenarios. This infection is very small like this and superficial. Yes, we can go just monotherapy, natamycin, but we have to wait patiently up to 3 to 6 weeks for the response to come. You should not get dejected with the 1 week, then we have to go for further management. In case of larger infection and deeper infection, we can go for a combination topical therapy. This is what we usually do, natamycin with one of the azoles. Nowadays, we prefer voriconazole. We can even sometimes switch over to amphob instead of natamycin. Don't combine natamycin with amphob because they belong to the same group. So we can switch over to amphob if it is an aspergillus or a dimetaceous fungus. And of course, we can go for other modes of delivery also. So the intrastromal is again one of the favored things a few years, 1 decade back. And it should be given properly like a barrage all around only. The same intravitreal concentration can be used, but you should not, don't try to poke in the central necrotic area. You will end up with perforation. So this can be done, but what the literature says, they have not found much evidence that intrastromal is really helping in treating these many of these cases when compared with only topical medication. This is what the literature says. But you have to remember, when you see a case like this, where most of the infection in the deeper layers or on the endothelium, still we go for intrastromal injections, mainly voriconazole. Amphob is another one which we can use, but amphob usually cause more inflammation. So we use voriconazole as intrastromal or even sometimes intracameral injection. But most of these cases are anecdotal. The response can be there, but of course, we are not going to lose anything. We can give and see, and otherwise we have to go for a surgical intervention if not responding. These are some of my old slides where we have given intracameral amphob. Those days voriconazole was not available. With repeated injection, as you can see, gradual response I could get. And even cases like this, I got when it flared up like anything, then gradually it started responding to the intracameral amphob. But these are anecdotal cases. We can't say that same kind of response we can get in all cases. Coming to the oral, again, Mutt too studied the oral voriconazole effect. But one problem here, we enrolled only severe cases. Cases which really like severe cases where they may go for a therapeutic graft. So those kind of cases. And here we have what we have found, there is no difference between cases treated only with the topical nata and voriconazole and with oral voriconazole. Not much of a difference in the instance of TPK. But another interesting finding in that study is when in the case of fusarium keratitis, when oral voriconazole was used, that it has a little bit leverage over, I mean, the instance of TPK is relatively less in fusarium cases, which is surprising because in MUT1, we have seen in fusarium, topical voriconazole is not of much value when used alone as a monotherapy. But here, in addition to the topical natamycin, when used oral voriconazole, even in severe cases in fusarium, it reduced the incidence of TPK. And then I'll just give one case example, one short example. A 57-year-old male presented with deep infection because already he was on treatment somewhere else for a month for a fungal keratitis. Again, there also the scraping didn't reveal anything, but clinically they treated him on natamycin with oral ketoconazole. And the only systemic positive history was bronchial asthma, for which he was mainly using inhalers and now and then some steroids. And he not a diabetic patient, and this was the picture initially. And the investigation, of course, our scraping also did not reveal anything because surface was almost healed. Everything was in the deeper layer, as you can see in the ASOCT. So we just continued the treatment, and we have decided to give intrastromal voriconazole because of deeper infections. 2 injections we gave at the span of alternate days. He started responding much better. So he went home, and then we continued the rest of the treatment. Then after a few days, he came back with a drop in vision, more symptoms, more pain, and the IOP has gone up like anything. And also the, as you can see, the infection is started going on to the endothelium, and this is the clinical picture. Sorry, I don't have a typical clinical photo. Again, we can see endothelial plaque, which is again going tracking towards the limbus and with the hypopion. So then we switched over to oral voriconazole, 200 milligram BID, and he started responding. After 3 weeks, the liver function was normal, but I thought 3 weeks therapy is more than enough, and he was responding. So I told him to stop the medication, continue the topical. And within 2 days, a few days, he came back with again a flare-up of infection. So again, I decided to continue the oral voriconazole. Now is almost on 7th week of the therapy. Now it almost settled down very well. And I thought like I'll give 1 more week voriconazole OD and then I'll stop. So these are the anecdotal cases. I cannot say that oral voriconazole is going to work in every case, but a very expensive drug for our standard, and also we have to keep in mind about the liver function. But in such cases, we can try. And coming to oral, other oral antifungals, of course, we didn't find the ketoconazole of any use, and even Dr. Sharma found the oral voriconazole also. In their study, not much of a big difference between oral voriconazole with the oral ketoconazole when they compared these 2 drugs. So, but still we can keep oral therapy in case of aggressive anterior segment infection. Even if we are planning for a therapeutic graft, we can start the oral therapy, preferably voriconazole if possible, and continue the therapy even in the post-op period for a week or 2, so that the internal infection, whatever has gone in, will be taken care of. So coming to the other mode of therapy is the collagen cross-linking Post-CXL is of much interest nowadays. But the riboflavin, what we use for the regular collagen cross-linking is not enough for infective keratitis. We have to go for either higher concentration, or now we have done a study on RBPDT, this Rose Bengal PDT, and this is the study enrollment. Everything is over about in the level of closing down now. The data analysis is going to start soon. Soon we can get the results from this. And the doctors from Boston Palmer, they can give their opinion because they were the one who initiated the study. Coming to the conclusion, it's an interesting time. And in the diagnosis, we need not stop only with confocal. Even on the molecular side, the PCR and the CRISPR and other areas, even smart stains. Now, a lot of research is going on where the diagnosis can be made more easier and faster. And that drug delivery methods also, we have to analyze more. The intrastromal, intracameral, we need not written them off. We have to look for other modes of delivery. And of course, the other modes of therapy like cross-linking and other things also we have to explore. Thank you.
Thank you very much, Revati. That was a wonderful presentation with a complete overview of the evidence-based preferred practice in general. May I request Dr. Sridevi to please introduce our panelists, and then we can have a comment. We'll start with Dr. Elmer too. So Sridevi, please.
Yeah, hi, ma'am. Thank you, ma'am. I welcome Dr. Elmer Tu, who's the Director for Cornea and External Disease Services at University of Illinois, Chicago. We also have with us Dr. Sonal Tuli. Ma'am is the Professor and Chair at Department of Ophthalmology, College of Medicine, University of Florida. And we have with us Professor Christopher Liu. Sir is at present, he has a lot of affiliation, in fact. So he's a medical director at Tongden Eye Clinic in UK. He's also the honorary clinical professor at Brighton and Sussex Medical School, UK, as well as the Department of Ophthalmology and Visual Sciences, Chinese University of Hong Kong. Sir is also the consultant ophthalmologist Cornea, National Treatment Center, NHS UK, and he's the lead consultant ophthalmology services at Hospital Authority, Hong Kong. We have all among our, so these are the three panelists that we have with us today. Over to Dr. Elmer Tu for his comments.
Those are wonderful talks. And I want to emphasize one of the things that we emphasize with our trainees, at least, is that for fungal keratitis, it's unlike bacterial keratitis. The treatment is, for bacterial keratitis, you have a gram-positive or a gram-negative. It generally is going to respond to a specific class of drugs. Fungal keratitis is quite different, and individual species and will often respond to some drugs and not others, and it's really very unpredictable. And because of that, I think it's important to have a plan to start with a drug, and it appears natamycin is probably the best drug to start with. But in the interim, and especially at least in the US, I'm not sure how quickly you can get antifungal sensitivities there in India, but I always tell our residents, have the antifungal sensitivities brewing while you're treating the patient, because you can usually afford to be wrong once with your first drug. You can't afford to be wrong with the second one, because by that time you're off to a TKP or intracameral extension. So you need to have that information with you, I think, when you're thinking about treating these patients, especially fungal keratitis patients. So that would be my takeaway.
Thank you, sir. So over to our next case presentation by Dr. Indulekha. Dr. Indulekha is a corneal fellow at Arvind Eye Hospital, Coimbatore. I think Dr. Arshi will be sharing Dr. Indulekha's slides because there was some issue.
Dr. Indulekha said she'll be trying once her internet connection stable. Ma'am, can you please share your slides?
Are my slides visible now?
No. Yes, but they're not in the slideshow mode, I think.
Now is
Yes.
visible, ma'am?
Yes. Yeah.
Good morning, all. Welcome to my topic, Beyond the Obvious, When Viral Isn't Viral. This present patient, 26-year-old male, he presented to us with a complaint of pain, redness, and photophobia, right eye since 1 month. He had a past history of injury with a stick, right eye, 1 year back, which was managed conservatively from the local hospital. But since then, he had occasional pain, redness, and photophobia, but therefore that no treatment was taken. Examination showed with a best corrected visual acuity of 6/6 in both eye. IOP was normal. Right eye showed diffuse minimal congestion of conjunctiva with 4 into 5 mm full thickness stromal scar infratemporal quadrant near limbus with superficial and deep vascularization. Corneal sensation was normal. The rest of the findings were within normal limits. Left eye was normal. Confocal showed scar tissue. There was no evidence of any microorganisms. And we treated him with topical antibiotics and lubricants and along with warm compression. 2 months later, he presented, and that time he was symptomatically better and vision and scar was remaining same. And then he lost follow-up. Later presented 13 months later with a complaint of defective vision in right eye since 1 month and redness in right eye since 15 days. That time the vision dropped to 6/60 in right eye and IOP was within normal limits. Right eye, on examination, there was diffuse congestion with cornea 8 into 8 mm, stromal haze with patchy stromal scarring with deep and superficial vascularization, along with endothelial deposits corresponding to the area of haze. Corneal sensation was intact, and the AC reaction couldn't be appreciated, and the rest of the findings were within normal limits. Left eye was normal. The B-scan right eye was normal. And our differential diagnosis were viral endothelitis, other infective keratitis, interstitial keratitis. And in view of endothelial deposits, we started with the topical antivirals and topical steroids, chloramphenicol plus dexamethasone eye drops 4 times a day, along with homide. And he presented 11 days after the starting treatment, and the vision further dropped to 1/60 in right eye, and IOP was normal. And we advised him to continue the same topical medication, and oral Valmac 1000 mg TDS was started. Since then, the patient was under regular follow-up. The stromal haze was gradually resolving, but the endothelial deposit and the vascularization was becoming more prominent. The endothelial deposit was confined to that space and it was not spreading. And oral and topical antivirals and steroids were tapered gradually. And around 4 months later, he was symptomatically same and vision was stable, low 1/60. And on examination, there was a cloudy membrane we could see along the endothelial level along with the stromal haze and the vascularization. That cloudy lesion, endothelial lesion was corresponding to the area of the stromal haze. And the ASOCT also showed a hyperreflective layer at the endothelial level. And in order to rule out other possible diagnosis, we planned AC tap and along with the removal of the membrane. The AC tap was given for PCR, pan-fungal, eubacteria, and virus. And the membrane was gently separated from the cornea. And it was taken out and sent for histopathology. The histopathology report showed positive for fungal in GMS stain and with a zone of infiltration involving posterior stroma and with the impression of necrotizing fungal keratitis. The PCR report was negative. And post-update 12, his vision was counting finger close to face in right eye, but the eye was more quiet and the endothelia was cleared with the stromal haze and vascularization. And we stopped all the current medication and started with topical and oral antifungals. And now he is under the current medication. The interesting feature of this cases, a typical presentation of the fungal keratitis, the long duration, and it was not worsened with topical steroids, and the eye is more quiet after removal of membrane. And I request the panel for further discussion of the case.
Yeah, if you, Indulika, I think you need to stop sharing the screen. Yeah. Thank you, Dr. Indulika. Yeah. Yes, ma'am. Yeah.
Or maybe we can request Professor Liu, if you have seen such infections in the various spectrum of patients you see across the world.
I don't actually see many of these cases, so I think I better defer to somebody more experienced.
Okay.
But I wanted to ask Dr. Tu a question, though, with regards to reference laboratory for fungal sensitivity. I used to think that fungal sensitivity is not nearly as reliable as bacterial sensitivity. Is that still the belief?
I don't think they're as reliable as bacterial, but they are much more reliable than they were 20 years ago. So, and there's much better clinical correlation. There have been a number of generations of testing and clinical correlations that make it more reliable in the sense that it gives you at least a pathway to secondary treatments.
Thank you.
With that case, I would say that one clue one gets is whenever one has given topical steroids, patient worsens. In our scenario, we always have to think that it's something else because particularly fungal. And this was a very classical presentation of what you would expect a viral keratitis to be, but she did mention that the corneal sensations were intact. So even though it sounds very silly, but I find that the corneal sensations is very, very useful to differentiate viral keratitis from other disorders. And I appreciate the fact that at every step, all the correct protocols were followed. So it's very important to keep an open mind and always keep the back history and the medication history in your mind when you're seeing how the patient progresses.
Right.
One thing I would add, though, that at that stage when you started suspecting a kind of a viral endothelitis, rather than giving topical acyclovir, I would have given oral acyclovir. But we have Manutosh's talk coming up next, and Dr. Sridevi will introduce him. But that's what I tend to do. Only if it's an epithelial keratitis, then I give a topical antiviral. But we'll wait for Manutosh's talk. So Dr. Sridevi, introduce Dr. Manutosh.
Yes, ma'am. So Dr. Manutosh Ray is here with us today. Sir will be giving a talk on viral keratitis. Dr. Ray is a senior consultant and head of cornea and refractive surgery services at the National University Health System, Singapore. Over to you, sir.
Thanks, Sridevi, for the kind introduction. Very good afternoon, ladies and gentlemen from Singapore. So I shall try to give an overview of the herpetic keratitis, and then probably I'll come to the management part, and hope that works for everybody. So let me share my is my slides visible?
Yes, very nicely visible.
All right. So herpes simplex virus, as you know, it is ubiquitous in human, and nearly 100% of those above 60 years harbor this virus in their sensory ganglion, including that of the trigeminal ganglion. So they say that, the herpes virus is a true chameleon when it comes to the eye infection, because it manifests in variety of the forms, and it usually poses kind of significant diagnostic and therapeutic challenges to the ophthalmologist. All right, so let's look at the magnanimity of the problem. So you know that this is the most common cause of the corneal blindness. Can I just minimize this because it's obstructing my slide? Oops. Okay, let's look at the magnanimity of the problem. This is the most common cause of the corneal blindness in the developed countries, but that is not only the fact, it is also the leading cause of the corneal blindness in the developing countries as well. More than 10 million people worldwide may have active herpetic eye disease at one point of time. So we all know this is a double-stranded DNA virus. I'm not going to go into detail of that. We know that HSV1 that is basically involved in the ophthalmic infection. And usually the primary infection that occurs in the childhood, and it usually spread by the droplets. Most of the time it goes undetected. First 6 months of your life is usually protected by the maternal antibody. Usually the symptoms are generic, and most of the time you don't need any treatment. All right, most of the time it goes undetected. And this is what you see in your most of the clinical scenario. I mean, this is what you are seeing in your practice is probably the recurrent corneal infections. Typically, these are unilateral. However, you do encounter some bilateral cases, maybe less than 3% of the cases. But if you do see this, think about more serious conditions. It could be some systemic conditions like atopic dermatitis, or patient may have been taking some systemic steroids, or even serious infections like HIV. Anatomically, we all know that herpes simplex keratitis can be classified into epithelial, stromal, and the endothelial, and each variety has their own sets of presentations, and I will come to that one by one. So dendritic keratitis is the most classical form of the epithelial keratitis. As you know, that it has kind of raised borders with the terminal bulbs. It typically stains with the rose bengal and the fluorescent. And even when the infection dissolves, you can see those superficial dendritic scar on the cornea. The geographic ulcer is basically an extension of the dendritic keratitis. When it is untreated, or patient comes late, or patient is immunocompromised, or patient may have used some kind of topical steroids by somebody. but you still can see this dichotomous branching of the terminal bulbs at the periphery, and it also typically stains with fluorescent and the rose Bengal. This is probably the most, a little bit of undetected or under-detected conditions rather. We call it a herpetic marginal keratitis. Typically, you have a linear limbal kind of lesion. Most of the time, you may diagnose this as a marginal keratitis or PUK. You may have given some steroid and patient is not improving. So if you see this kind of lesion with a kind of, loss of corneal sensation and a little bit of higher level of suspicion, probably can diagnose these conditions and treat accordingly. The most serious form of the epithelial keratitis is probably neurotrophic or the metaherpetic keratitis. My understanding of the metaherpetic keratitis is that when a neurotrophic keratitis follows a course of the dendritic or geographic ulcer, you call it a metaherpetic. But when it happens de novo, for example, you have a cerebellopontine angle tumor, which has been taken out and patient develop neurotrophic. So that is your neurotrophic, not metaherpetic. So an example, this is a probably patient of geographic ulcer or dendritic ulcer, gone to the GP, given steroid, eventually come with the geographic ulcer and progress to neurotrophic keratitis. So this is a metaherpetic keratitis rather than neurotrophic keratitis. Okay, so why the epithelium failed to grow in neurotrophic keratitis? A couple of factors, maybe lack of neural derived growth factors, maybe toxicity from the long-term use of the antivirals, or even the low-grade stromal inflammation. There could be problem with the tear films. Many things can be responsible for this. Let's move on to the stromal variety. Both stromal and the endothelial keratitis are basically an immune-related response to the non-replicating viral particles. Okay, so in both this variety of keratitis, usually the iris as well as the trabecular meshwork will be involved. So you would expect that these are the patients who will have high intraocular pressure most of the times. This is the mildest form of the stromal keratitis. We call it as immune stromal keratitis. It usually manifests as a focal or multifocal diffuse stromal opacity, is usually associated with a kind of partial or complete immune ring. And usually you will have a stromal edema. Maybe you have some kind of occasional cells into the anterior chamber. But the more serious form of the stromal keratitis is the necrotizing stromal keratitis, where you have a severe stromal inflammatory response to the live viral particles. As I said, these are the patients who will be associated with the uveitis and trabeculitis, and most of the patients will have a very, very high intraocular pressure. And in serious cases, sometimes you can see the corneal melting or even perforation. And moving on to the endothelial form of the keratitis, well, a bit of controversy here. Disciform keratitis, in our residency, we learned that this is a stromal keratitis, but truly this is an endothelial keratitis, localized endothelial dysfunction. Okay, so you typically see this disc-shaped area of corneal edema, characteristic keratic precipitates. You may look carefully, might see a little bit of cells into the anterior chamber, and typically you don't see any epithelial involvement. The keratouveitis, herpetic keratouveitis, it is where the uveitic component predominates than your keratitis component. So what you see here, you basically see the granulomatous uveitis with the large mutton fat keratic precipitates. This, the KPs are usually diffuse in manner. That means they are diffusely distributed into the endothelium. And patients usually have a significant morbidity from the posterior synechia, cataract, glaucoma, and so on. So if you encounter a patient of unilateral uveitis when it is associated with high intraocular pressure, I think the first thing you should rule out whether the patient has a HSB keratouveitis. Well, this is the armamentarium all over the world that is available to tackle these conditions. And in Singapore, we have typically these three: cycloprid, ganciclovir, and valacyclovir. These are the three medications we use here. This is the treatment protocol that I follow for my patients. As Professor Radhika was mentioning, if I encounter a patient of epithelial keratitis, I just use topical antivirals alone up to 3 weeks. If it is a stromal keratitis, including disciform keratitis, I use topical antivirals as well as topical steroids. Steroids typically go up to 10 weeks with a tapering dose. And in case of endothelial keratitis, when you have a epithelial breach, I try to hold my steroid for some time. So I start with the antivirals for 2 weeks, and typically after 2 weeks, I start the steroid. We do encounter patients with high-risk recurrent keratitis, herpetic keratitis, like when the patient had a multiple episodes, when the patient is a post-keratoplasty, or patient has a herpetic infection and you are planning for a cataract surgery. So these are the patients who are fit for low-dose prophylactic acyclovir for a year. We call it a prophylactic dose, and this is according to the HAEDS recommendations. Neurotropic keratitis itself merits a separate discussion. I don't think I have a scope of discussing here in 10 minutes, but basic principle of treatment of this metaherpetic or neurotropic keratitis is to promote healing of the epithelial defect, right? So if the patient is using those toxic medications long time, including your antivirals, probably stop that, do tear supplementation, you may consider punctal occlusion. Bandage contact lens can help. TARS therapy in some cases, like patient who had undergone those cerebellopontine angle tumor resection or so on. In my experience, cord blood serum, they works pretty well. And in some cases, of course, you need a little bit of surgical intervention, including the amniotic membrane transplant. We do have a cord blood bank in Singapore. They innovated this kind of, this IV tubing. They segmentalize and they deliver to the patient's house directly. And the growth factor that has in the cord blood serum that really promotes the epithelial healing quite well. Okay, let's talk about a little bit of the newer agents of the neurotropic keratitis. We know that topical insulin being used worldwide with a pretty good results. Unfortunately, I don't have any experience because this has not been, approved to be used by Health Service Authority, that is the FDA equivalent in Singapore. So we cannot use the topical insulin, but probably the panel can later on discuss on that. We do have Oxervate. Unfortunately, I could not use Oxervate in my patients. We check with the vendors. For 8 weeks treatment, they quoted me around 95,000 Singapore dollar. People who are in India, that is equivalent to 65 lakhs rupees. So my patient could not really, they cannot afford this. Scope of the surgical treatment is not much in viral keratitis or herpetic keratitis, but in some cases you do need amniotic membrane transplant, especially the metaherpetic or neurotropic or even necrotizing stromal keratitis. In cases where you have huge crater, you can even think about this multi-layer EMT inlay over the onlay. In case where you don't have the amniotic membrane access to the amniotic membrane, you can even think about conjunctival flap or the tenon patch with a good surgical outcome. It has been described in the literature as well. Now, what about the corneal transplant? Yes, you do corneal transplant on herpetic eye disease in very, very selected cases. So the selected cases where your visual acuity is not correctable either with glasses or contact lenses, or of course, when you don't have any option, patient has a corneal perforation, melting, or so on, or even the patients with the one-eyed patient. So depending on your expertise, you can think about doing either penetrating or lamellar keratoplasty in this kind of cases. Why corneal surgeons hate to do a corneal transplant on herpetic patients? So this is the reason. Recurrence rate is pretty high, up to 44%. There is a high chances of rejection. You can see this non-healing epithelial defect, draft melting, secondary infection, and so on. So this is the reason why we try not to do this unless it is really necessary. However, according to the HAEDS study, if you cover this patient with prophylactic antivirals like your acyclovir for 1 year, the graft survival rate improves pretty dramatically. You can see that it can be up to 90% for the first year and up to 60% for the 5 years. It's not too bad. I mean, compared to the normal transplant. And of course, these are the patients, it has to be on topical steroids for the prolonged period. My final slide, what is the future direction for the herpetic keratitis? Well, glycoprotein subunit vaccine has shown some promise in decreasing the numbers and the severity of the recurrences. Still have to be kind of used in a mass trial. Newer agents like topical ganciclovir or cidofovir could be more effective and less toxic. The monotherapy with interferon has been tried before, but it isn't really effective, but it has been shown that if you use in combination, it can increase the efficacy of the cyclovir and the ganciclovir when basically they are used in combination. Thank you for your attention.
Thank you, sir, for that really comprehensive talk on viral keratitis. I will now invite Dr. Dana Yong, who's a fourth-year resident at the Department of Ophthalmology in National University Health System, Singapore. And after her presentation, we can go ahead with the panel discussion. Dr. Dana Yong, over to you, please.
Are you able to see my screen now?
Yes,
Yes.
we can see your slides. Yes.
Okay,
Yeah.
thank you.
Yeah.
A very good afternoon. Thank you for the opportunity to present a case in this international platform. I am Dana Yong, a Year 4 resident at National University Hospital, Singapore, and thank you to Professor Ray for this opportunity. We have a 44-year-old Malay female who presented with right eye pain and loss of vision. Visual acuity was counting fingers, and as seen on the right, there is a large central corneal ulcer at the visual axis. She was extremely photosensitive, hence anterior segment imaging was rather challenging. Background, a contact lens user who uses her contact lens daily, all hours of the day with very poor contact lens hygiene. Prior to presentation, she was pre-treated with dexamethasone and neomycin from her general practitioner. This is another anterior segment image showing the corneal vascularization from overuse of her contact lens. Cornea scraping was performed and she was started on hourly fortified cafazolin and gentamicin with atropine for pain relief. Gram smear had no organisms with 1+ white blood cells and culture had no bacterial growth. However, after 5 days of empirical treatment, there was still no clinical improvement. A hypopyon developed inferiorly as well. She was still in a lot of pain. Anterior segment optical coherence tomography was done and showed presence of an overlying epithelium, suggesting the infection was within the anterior stroma. Repeat scrapes now show gram-positive cocci, culture was still pending, and we sent off acanthamoebal culture. Vancomycin and levofloxacin was added on and cafazolin was ceased. Stromal puncture was performed to aid in antibiotics penetration. Eventually, culture came back to grow Fusarium species, which was confirmed to be Aspergillus. Natamycin 5% was commenced. A month into treatment, there was still no clinical improvement and patient was still in a lot of pain, and her pain treatment was even escalated to tramadol. ASOCT showed stromal abscess. Acanthamoeba culture was negative. She was also sent to another center for confocal microscopy, which also confirmed negativity in acanthamoeba. So what did we do next? She was counseled for corneal cross-linking versus therapeutic DALK, for which she opted for the former. This was done 6 weeks from initial presentation and the accelerated protocol was used. Post-procedure, antibiotics and antifungal topical eye drops were continued and steroids was added 2 weeks later. The epithelium started healing in and the epithelial defect eventually healed over 3 weeks after topical steroid was initiated. In total, it took about 3 months for the infection to resolve. There was still a large central corneal opacity with significant vascularization, and her visual acuity at this point was 6/60. She also had significant cataract. She was referred to our contact lens clinic and fitted with rigid gas permeable contact lens, which brought her visual acuity to 6/12. ASOCT here shows that the corneal scar opacity was predominantly confined to the anterior 2/3 of the stroma. Specular microscopy was not successful. She was very bothered by the large central corneal opacity as she worked in human resources, which required her to face clients all day. This was her pentacam showing irregular astigmatism. Also, the thinnest part of her cornea was 492 micron, which was still not that thin, and her cornea is flat with K1 and K2 of 37.7 diopter and 38.3 diopter respectively. As such, decision was made to proceed with manual DALK. Post-DALK, her visual acuity was 6/24 unaided, bearing in mind she has a rather significant cataract. The residual cornea was 154 microns and the clinical image is as above. The left-hand side is her right eye image at post-op month 10 after some sutures were removed. She underwent cataract surgery 2 days ago. Intraoperatively, there was extensive posterior side Nikkei. Iris hooks had to be employed. Her intra-op photo after IOL was inserted is as below, and the bottom right is her photo at post-op day 1 with a visual acuity of 6/15. And with that, thank you for your kind attention.
Thank you, Dr. Dana, for that very interesting case. I invite Dr. Sonal Tuli for her expert comments.
Dr. Sonal, can you please unmute? Sorry.
Yeah, ma'am, I
Very
think you're muted.
interesting
Yeah.
talk. Thank you. Both the herpes talk and the case presentation were very, very interesting. Both fungal keratitis and HSV can be very, very can masquerade as anything else, and we've all been fooled by cases that we thought were one or the other, and then ended up being the other thing when we finally came to a diagnosis. So I guess one of the questions I have is that we typically use when we treat fungal keratitis, because they're so difficult to treat, we always treat them with 2 antifungals, similar to what we do with bacteria. Does any of the other panelists do the same thing? We tend to, they tend to respond better. I mean, we do the intrastromals and intracameral injections too, if they are much deeper. But even for superficial keratitis with fungal keratitis, we treat with natamycin and either, and typically voriconazole. We can't get amphotericin in the US very easily anymore. What about the rest of you? Dr. Radhika, what about you or Dr. Revati?
So in North India, we do have Aspergillus more than Fusarium. And we originally, after the MUT trial, we sort of did our own study of adding voriconazole in recalcitrant natamycin-treated keratitis. And there was an added effect. But still, because of the MUT publication, we recommend that to start with natamycin, wait a week and see if there's no response at all after a week, then we add voriconazole, because Dr. Namrata's study had shown that adding voriconazole to natamycin has a beneficial effect. So first line, we start only natamycin, and then after a week, we will add voriconazole. That's our general plan. We are trying to get antifungal sensitivity, and it is very useful. So it takes time, of course, but if the person doesn't respond, then it's very, very helpful in knowing which way to go. And we'll have comments from Vanati for that. But largely, we will start with natamycin and then add voriconazole if it's not responding.
Yeah, unfortunately, we cannot get sensitivities in Florida. So, and we do have a lot of Fusarium. So I guess maybe that changes my treatment plan.
And perhaps you can try Revati's experience that you can start with natamycin and give oral voriconazole, because that's what they found helps with Fusarium, if Fusarium is your more common organism.
Yeah, one thing about voriconazole that's been interesting is if it's an older person, they can get some pretty significant visual hallucinations, which can be very, very scary to them because they think they're going crazy. So be careful about that in older patients.
Yeah, we have to adjust the dose as per.
That's very important. Thank you for alerting, because it can, and even sometimes acyclovir can lead to, in very elderly people, you don't know what the effect is going to be. Yes.
I would add the comment that we do have access to posaconazole here, and we published a few case reports, and it's much more effective against Fusarium than voriconazole.
I would like
Dr. Vanati, you had a question. Yeah.
Yes, I would like to add on to that. Yes, I did. We concluded a dual cohort study on comparing conventional therapy versus topical posaconazole for fungal keratitis, which was refractory to management over a period of 3 weeks. I think it's just about in PubMed right now, and our results showed fantastic results with posaconazole, given that we did not have resistance factors to posaconazole. That is a major thing, and voriconazole is still used in the agricultural industry, as the MUT trial pointed out, and that perhaps is also partially responsible for the increased resistance to voriconazole, which we are seeing. And much against, I think what we believe, I think natamycin is still effective against, reasonably effective against Fusarium species as well. And antifungal resistance is a factor which is going to be of increasing concern in the coming days here. So antimycotic sensitivity in fungal keratitis is perhaps being recommended as a routine in protocols when we are managing fungal keratitis in our practices in a bigger way here. But posaconazole, yes, is giving good results. Its sensitivity is very good here, and the concentration levels required for managing fungal keratitis is lesser compared to the other antimycotics we have right now. And when we look at their resistance factor, this is giving the best MICs against almost all range of corneal pathogenic fungi which we are seeing right now. That's our initial experience, and we have now just we are moving into an RCT to see how effective it really is in our practices.
Thank you, ma'am. Okay, I shall now invite our next speaker, Dr. Ritika Makhija. She is a consultant of ophthalmology at Sussex Eye Hospital, Brighton, and she'll be talking about contact lens-induced microbial keratitis. Dr. Ritika, please. I think you're muted, Ritika. I can't.
Yes. Can you hear me now?
Yes, yes, yes. I can hear you.
Yes, thank you, Dr. Sridevi, and a big thank you to Dr. Radhika for the kind invitation. I have no financial interests. I'm going to be giving a brief overview on contact lens microbial keratitis. Can I just check if we are through to the next slide?
Yes, your slides are moving. Yes.
Yes, yes.
Thank you. So contact lenses, as we all know, they are widely used for refractive correction, and estimated 140 million individuals wear contact lenses worldwide. So this is a really important risk factor for microbial keratitis. And in the United States and Europe, it is the #1 risk factor for developing an infection in the cornea, which we all know can lead to corneal blindness, which is an important cause of blindness all across the globe. The incidence of microbial keratitis amongst contact lens wearers can vary, and it has been reported that it can be up to 80 times higher than someone who doesn't wear a contact lens. So what really happens with long-term contact lens use? So there's a degree of corneal de-epithelialization, degree of hypoesthesia, and chronic hypoxia. And all these changes in some way or the other contribute to the fact that cornea is immunocompromised and is more...
I think there is some issue with the audio.
I can hear.
Any better now?
I can hear too.
You're
It's
okay.
really
You can
audible here
continue.
as well.
We can hear you, yes.
Okay, thank you. And all these factors, in a way, sort of make the cornea more prone to and more susceptible to getting infections. So there are a range of things which can happen with contact lens use, and there are some non-infectious manifestations like contact lens-induced red eye or peripheral ulcers, which may often just be sterile infiltrates, papillary conjunctivitis, and neovascularization. But the worst of all is microbial keratitis, which is what I would be focusing on this talk. So the pathogenesis is quite complex and multifactorial. So there's a degree of superficial epithelial injury that would be induced by contact lens wearer, which would in turn make the cornea susceptible to infection from an external pathogen. But at the same time, there are reduction in the tear fluid exchange while blinking, which results to a degree of tear stagnation and formation of a biofilm, which is a very important factor for vast majority of contact lens infections, including Pseudomonas, fungal infections, and acanthamoeba. And also there is some evidence to say that the tear film biochemistry alters, which can also reduce the immune response of our tears. Typically, when we look at risk factors, there are two factors which always stand out. One is the type and the duration of the contact lens and the usage of the contact lens. So it is seen that soft contact lenses have a higher risk than rigid gas permeable contact lenses, and extended wear lenses will understandably also have a higher risk as compared to daily disposable. Overnight wear, whether it's for soft extended wear contact lenses or orthokeratology, increases the risk quite significantly as well. And then, of course, the usage by the person who's using the contact lens, overwear, using damaged lenses, inadequate disinfection or contamination of the contact lens solution case, they're all quite important factors. Poor contact lens hygiene practices like lack of hand washing, replacement frequency of the solution, the way the lens case is used, and also using unregulated, non-prescription, internet-based lenses are a risk factor for higher risk of infection. And as we all know, the other notorious causes of swimming with a contact lens on, or showering, or using a hot tub, which is more common than ophthalmologists may think. And while preparing this presentation, sharing lenses, I've realized, is also quite common, and some studies have shown that up to 14% of the people would actually share lenses, and this is quite common for non-prescription or cosmetic contact lenses. And lack of supervision and a routine follow-up. So 50% of asymptomatic patients who presented for a routine visit had some form of complication indicating contact lens overuse, which highlights the importance of supervision while using contact lenses. So I've quoted these figures from a study, but this is quite representative of what we all see in clinical practice as well. So as you can see, the rigid gas permeable lenses generally have a lower risk of contact lens keratitis as compared to daily disposable or soft contact lens that are taken out overnight. And the highest risk is wherever you use the contact lens overnight. What I found really interesting is that in a survey conducted in the US, in 1,000 contact lens wearers, almost 1/3 reported having visiting a physician at least once for a red eye. And only 1% reported following all the directions correctly relating to contact lens hygiene. So this really highlights the importance of health education in such cases. A recent review tried to give the risk, the magnitude of risk for the various risk factors. And as you can see, excessive and overnight wear and poor contact lens hygiene remains the most important risk. And the other risks are swimming, scant experience, and ordering contact lenses online. There are, however, some non-modifiable risk factors as well, such as male gender, young sex, lower socioeconomic status, but their relative risk is much less compared to the other more common driving factors. Now, Dr. Sridevi has given quite a good overview of the diagnosis of microbial keratitis in general, but there are some special considerations that I would like to draw your attention to for contact lens keratitis. So, of course, the history of contact lens use and the onset of symptoms and any environment and patient-related factors are very important to identify, especially if it's a first presentation. And this is an opportunity for the eye care professional to promote health education and to give advice about correct contact lens use. It's very important to examine the other eye. Often you'll find signs of contact lens overuse or some signs in the other eye as well. And sometimes even a small peripheral corneal ulcer, which the patient may not have noticed. And in addition to taking corneal scrapes, as and when indicated, if at hand, it's very useful to also send the contact lens case and solution for microbiology. Now, the common culprits remain pretty much in line with what we see for microbial keratitis as a general. So bacterial keratitis remains as the most common cause, of which in varying proportions, Pseudomonas and Staphylococcus species, both coagulase negative and positive, are implicated. Acanthamoeba remains a very important cause of contact lens wear, and in fact, in various studies across the globe, up to 85% of the cases of acanthamoeba are actually linked to soft contact lens wear. Relatively less common are fungal infections. They're more common in tropical and subtropical keratitis. And they're also particularly common when patients need extended soft contact lens, particularly therapeutic contact lenses for long durations. And based on the geographical area, they can be either the filamentous fungi, Fusarium or Aspergillus, or Candida, which is relatively more common in temperate areas. Culture positivity rates for any microbial keratitis can vary greatly by range. So in a recent study, the positivity rates in the UK were somewhere between 1/3 to half of the cases, and they were almost as high as 2/3 in India. A recent study which was done in Alexandria, Egypt, on contact lens microbial keratitis, they found that acanthamoeba was their most common pathogen. And this is now being seen in some recent studies, though even now all across the globe, bacterial isolates do remain the most common cause. But it's important to note that acanthamoeba is increasing in incidence worldwide. Mixed infections are also not uncommon, and fungal infections remain generally the least common of contact lens keratitis. Now, when seeing bacterial keratitis, it can present from a small, innocuous peripheral infiltrate, which often responds very well to treatment, and it can also range to a very fulminant gram-negative bacterial keratitis, often a Pseudomonas. As you can see, there's a central ulcer with infiltrates, and the remaining cornea is very edematous, and there's a hypopyon. So these are generally pointers to a more severe infection, often a gram-negative infection. This is a patient I saw recently. This is a female in her 60s who has been wearing extended wear monthly contact lenses for over 3 decades. And she has never had any infection, but she recently went on a holiday, went swimming in the sea in Costa Rica, and presented with severe bacterial keratitis. So these photos are day 3 of having treatment with a combination fortified topical antibiotics. Initially, she had bilateral hypopyon and bilateral peripheral ulcers, which you can see are settling now. Now, it is important to clinically a very sudden presentation, sudden onset hypopyon. So we still treated the patient as bacterial keratitis. Of course, we sent samples for acanthamoeba. So far, the patient's shown good response to antibacterial therapy, and nothing has come up on the cultures. But it's obviously important to keep acanthamoeba as a possibility in these cases. Often, we initially start empirical therapy with a broad spectrum antibiotic cover, which can either be monotherapy with a fluoroquinolone. Ciprofloxacin, ofloxacin, and levofloxacin are approved by the US FDA, but moxifloxacin is also a very commonly employed agent in the rest of the world. Combination fortified topical antibiotics, generally a combination of beta-lactam and aminoglycoside, are also widely used. In many areas now across the world, they are reserved for more severe cases or those cases not responding to monotherapy with fluoroquinolone. And in cases where compliance and adherence may be a concern, subconjunctival antibiotics may also be considered. So this has been taken from the preferred practice. I'm sorry, my screen has disappeared. Yes, so this has been taken from the preferred practice pattern from ophthalmology. And as you can see, generally, fluoroquinolones do have a very broad spectrum of action against both gram-positive and gram-negative bacteria, and also with some level of cover for mycobacteria and atypical bacteria as well. This is taken from a recent review of contact lens associated bacterial keratitis. And this table is basically showing studies from all across the globe. And you can see how monotherapy with fluoroquinolones is a very common preference as a first line, and is also the first most effective antibiotic in many cases. Now, coming on to acanthamoeba. Generally, India and Indian subcontinent is known to have a highest incidence of acanthamoeba at 15.2 cases per million per year, followed by New Zealand, Egypt, Portugal, and the UK. But we are seeing an increasing incidence worldwide. Even in clinical practice, we are seeing acanthamoeba more common here in the UK than we did earlier. And this has been documented. There was an outbreak in Southeast England during the early 2000s, and it was seen that there was an approximately threefold increase compared to the preceding decade, which is very significant. Now, there is, as Dr. Sridevi has previously alluded to, there are various diagnostic modalities, microscopy with grams or genes of stain, molecular testing with PCR may be particularly useful. But the traditional and the conventional method is to culture on a non-nutrient agar enriched with E. coli. And now newer modalities like in vivo confocal microscopy, which understandably may not be widely available, and also anterior segment OCT. Often, however, as ophthalmologists, we may have to rely just on our clinical findings and possible lack of response to other conventional antimicrobial therapy. Now, typically, we describe acanthamoeba keratitis with either a ring-shaped stromal ulcer or the classical radial keratoneuritis that you can see in the photo on the right. Sometimes they can give the appearance of a dry fungal appearing ulcer as well. And sometimes you may see a more florid infection, as in this photo. And you can also see the cyst as seen on in vivo confocal microscopy on the right. But very often what happens in clinical practice is they will present very atypically. You'll possibly see just an unhealthy looking epithelium or just some very mild epithelial, subepithelial changes at the beginning. Sometimes even a dendrite or a pseudodendrite. So our teaching says that any sort of unhealthy epithelium or even a dendrite in a patient with contact lens wear, we always send scrapes for PCR for acanthamoeba. So this was a gentleman I've seen in the past. He was a male in his 70s, has been wearing soft contact lenses for over 4 decades. And initially he was misdiagnosed as dry eye and then subsequently viral keratitis. But he did end up with getting a culture positivity for bilateral acanthamoeba keratitis. Fortunately, he responded very well to treatment, had cataract surgery later, and had a good prognosis. But quite a good proportion of the cases do not have a very good prognosis because they're often very difficult to treat. They're often misdiagnosed, which delays the treatment, and they generally carry a worse prognosis just as a natural course of the diseases. And many patients do end up requiring surgical intervention. So we have some treatment options available in the form of biconides, which are commonly available, and diamidines in the form of propamidine. And there has also been evidence to suggest that aminoglycosides and imidazoles may also have some activity against acanthamoeba. Generally, as a first-line therapy, a combination of chlorhexidine and propamidine is advised. PHMB is advised as a second-line therapy along with hexamidine and pentamidine, and the others as third-line therapy. Often what happens is that because these are still relatively uncommon infections, we don't always have all the first and second line therapy to hand. So we often start with a combination of 2 drugs initially and then see the response. It's important to note that propamidine can be very epitheliotoxic, and it's important to titrate all these medications to look at epithelial toxicity and the response. Now, lastly, very briefly, touching on fungal keratitis, this has been covered in detail, but I would just like to highlight a case that I saw recently. So this is a male patient in his late 40s who presented with a typical mid-peripheral contact lens ulcer, treated as a bacterial keratitis, showed a good initial improvement for 1 week, started getting worse with a significant anterior uveitis, at which point he was given steroids as well. Ultimately, things kept going downhill. He was rescraped at 4 weeks and had a corneal biopsy at 6 weeks, but unfortunately, nothing revealed any causative organism. finally ended up requiring an emergency PK at 7 weeks, which later showed that this was Fusarium keratitis. Now, I'd like to highlight fungal keratitis, especially filamentous fungus, are not very common here in the UK. And it was only after a PK that we found out that he had Fusarium. And on probing, he possibly unsuspectingly, all he was doing, he was gardening with his contact lenses on, and he's generally someone with a very good contact lens hygiene, but unfortunately you can still develop very nasty infections. He ended up having a PK which again had a secondary infection, and he needed a second PK. There was a lag in treatment with natamycin because it's not very easily available, and we had to import it, and we were initially treating him with voriconazole and amphotericin B. So treatment is a combination of polyenes or azoles.
So can we quickly go to the end?
Yes, so this is my last slide. Just the take-home message is, like Professor Liu said, that prevention is more important, so patient education is the key. Have a generally low threshold for corneal scrapes and a higher suspicion for acanthamoeba keratitis in these cases, and aggressive treatment may often be needed. Thank you.
Thank you, Dr. Ritika, for that wonderful talk. Now, I shall invite Dr. Kumar Karthike for the case presentation. Dr. Kumar Karthike is a senior resident in Dr. R.P. Center for Ophthalmic Sciences under the Cornea, Cataract and Refractive Surgery Services.
Good morning, everyone. Are my slides visible?
Yes, Karthik, they're visible.
Good morning, ma'am. Good morning, everyone. So I'll be presenting a case on post-CXL keratitis. So our patient was a 11-year-old girl with a known case of vulnerable keratoconjunctivitis with
Now,
progressive keratoconus.
Karthik, just put it on slideshow, please. Yeah, perfect.
So our case was a 11-year-old girl, which was a known case of vulnerable keratoconjunctivitis with progressive keratoconus, and she has already underwent CXL in her left eye. In the right eye, she underwent accelerated corneal collagen cross-linking, which was an epithelial off procedure, and a bandage contact lens was placed in the immediate post-op. We followed her up on the post-op day 1. BCL was found to be in situ, and there was no signs of infection. On the day 3 of presentation, she complained of pain, redness, and diminution of vision in right eye since last 1 day. On ocular examination, her visual acuity in right eye was hand movement close to face with projection of rays being accurate. The conjunctiva was diffusely congested. On corneal examination, 3.2 millimeters of hypopyon present, and the rest details were not visualized. This was the clinical picture on the day of presentation in the right eye, and left eye. So we took out the bandage contact lens and we sent it for both bacterial and fungal culture sensitivity. On bacterial sensitivity, it was found out to be positive for Staphylococcus aureus, and it was sensitive to chloramphenicol, gentamicin, tobramycin, vanco, and amikamycin. And fungal culture sensitivity showed no growth. So we made the diagnosis of right eye post-CXL microbial keratitis with left eye venereal keratoconjunctivitis with keratoconus, status post-CXL in left eye. So we admitted the patient and started empirically on fortified antibiotics. In right eye, we started concentrated cefazolin 5% 1 hourly, concentrated tobramycin 1.3% 1 hourly, antiglaucoma brinzolamide BD, homatropine 2% QID, and the patient was shifted to concentrated vancomycin and tobramycin according to the sensitivity report. In the left eye, we continued eye drop olopatadine HS and carboxymethylcellulose 6 times per day. So this was the response to the fortified antibiotics the patient had. The initial day of presentation, she had a large epithelial defect with infiltrates with hypopyon, which responded to the fortified antibiotics. On the day 10th, we can see the epithelial defect has reduced to the size of pinhead with infiltrates measuring just 4 into 3.5 millimeters with surrounding scars. And the patient was tapered to the 4 hourly fortified antibiotics. And subsequent day, that is the day 20, the clinical picture showed no epithelial defect. There was central 2 into 2 mm of infiltrate with 360-degree peripheral vascularization, and fortified antibiotics were also tapered subsequently. So on the day 10th, we noticed that there was no further epithelial defect was seen, and we started the patient on topical steroids with the sequential ASOCT scans to monitor the corneal thickness. So this was the day 1 when the patient was started on topical steroids, and after 4 days, this was the clinical picture with the vision improved to finger counting at 30 centimeter. There was minimal infiltrate of 2 into 1.5 mm, and ASOCT shows the compactness, and there was central thinning, which was also noted clinically. So this was the condition at discharge of my patient. Her vision was finger counting at 1 meter with IOP of 18 millimeters of mercury. There was central leukomatous corneal scar of 4 into 4.5 millimeters. So we made a diagnosis of post-CXL microbial keratitis. Patient presented to us on the day 3 of the procedure and found positive to the Staphylococcus aureus. So the overall incidence of post-CXL keratitis is usually very low, with gram-positive cocci being the most causative organisms. Usually patient presents at 3 to 5 days post-intervention. In our case, we removed the epithelium. It was an epi-off procedure. It was an accelerated procedure. Bandage contact soft lens was placed. She was already a case of venereal keratoconjunctivitis. She had a history of chronic steroid use. So various studies have also found out that the duration of procedure, the duration of re-epithelialization, usage of bandage contact lens in the post-op, history of atopy, history of chronic steroid use, all these factors have shown a causative association for post-CXL keratitis. So immediately we send the BCL for culture, and the organism which should be treated promptly and should not be missed. On culture sensitivity, organism shows high resistance, usually methicillin resistant Staph aureus being the most potential organism. Hence, early and prompt treatment should be started. Also, initiating topical steroids, which we started on the day 10th in our case, has shown proven effect in the large central bacterial corneal ulcers. But again, being a double-edged sword, it causes corneal thinning, might cause perforation. So the subsequent serial OCTs are recommended. Thank you for your kind attention.
Thank you, Dr. Karthikeya, for that very interesting and well-managed case. I invite any of the panelists or the speakers to give their inputs.
Dr. Vanati, would you like to mention anything?
I think my ma'am has left. She had another commitment.
We have...
Ma'am is right there, ma'am.
Yeah, Vanati is there.
Yeah.
Okay.
Yeah. So I think contact lens usage is on the increase here, and infections due to contact lens are something which are a real concern here. And I think shifting on to daily disposable contact lens wear is going to be a major advantage for all of us. And now with the advancements available in contact lenses, I think there are a variety of lenses here, and corneal ectasia with visual rehabilitation improving with some of these advanced lens patterns, which we have many sclerals here. There is a particular concern, and where we are using therapeutic contact lens wear for ocular surface diseases here, again, infection is a reality here, and that's something which we need to balance vis-a-vis the comfort and the vision improvement which we get in these patients here. So by and large, the take-home message will be that those long-term contact lens users will have to be in regular touch with their corneal physicians to look at the health of their cornea and the ocular surfaces, which is imperative. And early management, early detection, early diagnosis, and appropriate therapy in the initial phases is going to be the emphasis when we are managing these infections.
Thank you, Vanati. I'll just make a quick input from myself that talking about the case about cross-linking in a case of in patient of keratoconus and getting post-CXL infection, one should bear in mind that the ocular surface should be stabilized and the VKC should be kept under control as far as possible. They do have a tendency to have more commensal organisms, so we in fact do get a conjunctival swab, because just even getting that one case is one case too many. So therefore, we now get a pre-treatment conjunctival swab, and often it does come positive. So then we defer the the procedure. And the third change we've made is that we don't give the topical steroids till the epithelium has healed. So we do the cross-linking, put the contact lens on, see the patient after 2 or 3 days, usually 3 days, remove the contact lens, and then start the topical steroids. And I just like to take this opportunity to thank everybody for joining and their very, very valuable contributions to this session. I'm very, very grateful. Thank you.
Thank you.
Thank you, ma'am. I just request Professor Namrata Sharma, ma'am, to close the session. Ma'am.
Namrata, are you there? There are a lot of sessions going on.
Yeah, yes, ma'am, I believe, yeah. Okay, then, ma'am. So this was a really wonderful session, and I request all of you to please switch on your cameras so that we can have a. Ma'am, I think you're muted. Yeah, yes, ma'am.
If Dr. Manutosh is there, maybe. Hi, Manutosh. Lovely to see you. What about Dr. Dana? So we can take one group photograph.
Yes, ma'am. Just if everybody could switch on their cameras. I think Dr. Dana. Yeah, we're all there now. Yes.
Okay.
So just
taking the photo and just say you've taken it.
I think Dr. Arshi is taking it.
Yes, I'll be taking it.
Yeah.
Smile, everyone.
Yes.